Hello and welcome to our presentation about understanding the individual characteristics that drive health and social care utilisation using a linked dataset across 5 settings of care for adult residents in Barking and Dagenham. My name is Jenny Shand and I work at UCL Partners and as a researcher at UCL. And the work I'm about to share with you was done in collaboration with Professor Steve Morris and Dr. Manuel Gomes. Marmot describes a health paradox, whereby those that are tasked with health are only responsible for health services and not for the key determinants of health that lie outside the healthcare system. And indeed, it's suggested that only 10 to 15%, or 11% in the research that we've referenced on this slide, of the health of an individual is attributable to the access to high-quality health services. So the opportunity for other sectors to improve health is therefore extensive. Coupled with this, the reliability and availability of hospital and primary care datasets have led to a concentration in research on these two settings. Findings demonstrate an association between age and morbidity, which is most frequently measured as the number of long-term conditions an individual has, with increased service utilisation. And as such, frail elderly populations and those with multiple long-term conditions are both policy and service priorities. However, it struck us that this is only part of the system-wide picture, as it excludes key settings of care, namely mental health, community services and social care. And whilst representing a smaller proportion of the total NHS and social care costs, these services may serve different population groups. Our study aimed to understand the variables associated with higher health and social care utilisation across all 5 settings of care, and therefore broaden the perspective than is seen in the literature to date by having that system-wide perspective. And specifically, we wanted to understand which factors determine the probability of using health services overall and by setting of care, which factors are associated with health care costs overall and by setting of care, and by that we mean increased levels of service use for those that had one. And are there factors that are associated with higher service use that are different across the different settings of care? And in order to run this project, we developed an individual level linked dataset in Barking and Dagenham, which is a deprived borough in East London. We had the fortune of working with a council that had already connected an awful lot of their different departments' datasets together. So we had wide access to information about residents and therefore the social determinants of their health. We also were working in a borough that had a linked health dataset across hospital and primary care, which created a strong foundation for adding in additional information. What we did is we brought together the descriptors of the individuals from both primary care records and from the council datasets, and joined that with the service use information we had across 5 settings of care: hospital, primary, community services, mental health and social care service use. And for each unit of activity we applied a cost, which was either the tariff cost or the unit cost of delivering that service. And that gave us, for each individual, over the 12-month period we were looking at, which was the 1st of April 2016 to the 31st of March 2017, an annualised cost of service use for each setting of care. And what that did is it gave us a primary outcome measure that enabled us to compare across the different settings of care with a common measurement. So this was cost-weighted utilisation. The linked dataset had 201,393 confirmed residents of Barking and Dagenham in, from a snapshot taken on the 1st of April 2016. Now, confirmed residents are defined as those who are present on the address register from the council and on either another council dataset, the GP registry, or both. Those who died or moved out of Barking and Dagenham before the 1st of April were excluded, before the 1st of April 2017 were excluded from the cohort as they had less than 12 months activity data, and those who died have specific patterns of healthcare utilisation that could change our interpretation of the results. Children were also excluded because their patterns of service use differ from adults. We also excluded those for whom we couldn't match the council information with an NHS number, and those that were registered with a GP practice outside of Barking and Dagenham. And this left us with a study cohort of 114,393 adults who were living in 58,929 households. So the cohort itself, as I mentioned, Barking and Dagenham is a highly deprived borough. It's the most deprived borough in London according to the 2019 IMD index, and it remains the 12th most deprived in the UK. The population is relatively young, so as you can see, the male-female distribution is a higher level of females than males, and the majority, 62% of the cohort, were aged 19 to 49. 17% of them had 2 or more long-term conditions. 59% were overweight or obese or morbidly obese. And the number of individuals living in a household in receipt of housing benefits, there were 30% of the cohort were receiving some sort of benefit. With regards to the cost data, the proportion of individuals that had either no cost or had a cost in each setting was different by each of the settings of care. So with primary care, there was a very small proportion, only 15%, that had no costs, but a much larger proportion had no costs in mental health and social care. And what this meant is that when we were planning our methodologies for running the analysis, we needed to look at different kinds of regression frameworks in order to account for the large mass of zeros. So we wanted to obtain the effect of the covariates on the overall population mean cost of service use. And in order to do that, we used a two-part model, which firstly modelled the odds of having a service cost in that setting and overall, using a logistic regression model. And then secondly, conditional on having a cost in that setting, a generalised linear model was used of individual cost-weighted utilisation against all of the variables that the literature suggested were likely to be associated with increased costs. We ran 6 separate models, the first looking at the aggregate total cost-weighted utilisation across all 5 settings of care, and then the subsequent 5, a different model for each setting of care. And for each of the models, we adjusted for the same covariates, which are the ones that are listed on this slide. So we looked at socio-demographic characteristics, health variables, and household variables. And for each of the models, we kept the reference group consistent. For the total cost model, we found the following covariates were associated with increased odds of having a service use and increased mean total cost. So with regards to socio-demographic variables, increasing age, being female, being of non-white ethnicity, and having a carer were all associated with both the probability of being a service user and that increased total cost. With regards to health variables, it was being an ex-smoker or a smoker, being obese or morbidly obese, and then the presence of more than one long-term condition, or indeed the presence of any of the 16 long-term conditions that were included in our model. With regards to household variables, being in a household in receipt of employment support allowance, income support, and standard housing benefit were all associated with a higher probability of being a service user and an increase in the mean total cost. One area to note is about the count of the long-term conditions. Because we also adjusted for the specific conditions, there was an interaction between the count of conditions and the conditions themselves. So the individual conditions controlling for the count led to increases in the mean cost at an individual level across all settings, but the additional effect of the number of conditions the person had on the mean cost, conditional on the individual conditions, was subadditive, and that's why in the green highlighted boxes you can see that in the two-part margins the additional cost for each addition of a count of LTC is going down, and this is because of the interaction between the two. So in the orange box, this shows when we ran the model again with all of the covariates but not with the individual 16 conditions, the presence of more than one long-term condition significantly increased the odds of having a service use, and there was a significant increase in service costs as the number of conditions the individual had increased. And this is what we had expected to see. So running the 2 separate models are now allowed us to interrogate our results in further detail and be able to interpret them. Across the total cost and the setting level models, there were similarities and differences in the findings. There were similar findings for each of the settings with regards to increasing age, which was associated with increased odds of having a cost and increased costs. The one exception was in mental health, and if you can see here on this slide, on the left you can see the raw mean expenditure by setting of care, and on the right you can see the two-part model adjusted mean expenditure, and the dark blue line, the navy blue line, is mental health. So that is actually not associated with age in the same way as it was in the other settings of care. All conditions were associated with increased odds of having a service cost. Employment support allowance, increased odds of having a service cost, and increased adjusted means across all settings of care. And similarly, living alone increased the odds of having a cost in 3 of the 5 care settings, and it had a statistically significant increase in the level of cost in all settings except for in social care. The main differences were with regards to age, as we show on this slide, and with regards to gender for mental health, and the individual conditions that were most strongly associated with the increased adjusted means at the setting level. These were often different depending on the different settings of care. So, for example, in hospital, cancer, heart failure and palliative care each led to the highest differences in adjusted means, whereas for social care it was about learning difficulties and dementia. Notably, dementia had the highest adjusted mean cost in all settings of care, but it was smallest in the hospital setting, where the adjusted mean cost of dementia was only £322 higher after adjusting for the other factors. For household variables, again, there were consistent findings across all settings of care with regards to employment support allowance. Our findings are largely consistent with the literature, particularly around the impact of age, gender and multimorbidity on service use. However, the inclusion of all 5 settings of care enabled us to look at the differences by setting in a different way, and we particularly found interesting pieces around mental health service use. There are several limitations to note. This was a cross-sectional analysis using only a single year of data, so longitudinal patterns were not evaluated, which would have provided more clarity on whether the impact of the factors explored in this study were likely to change over time. By defining multimorbidity as a simple count of long-term conditions, we weighted all diseases equally. There are wide definitions out there of multimorbidity, which have got more sophisticated methods of weighting different diseases according to their acuity and severity that they have for the patient. And finally, although the cohort was large, it's a very deprived population with no individuals in the least 2 deprived national quintiles, so this may have an impact on the generalisability of the findings. So what are the implications? There are 2 particular pillars that we feel this could contribute to. Firstly, informing integrated care. The importance of looking at a whole system picture, bringing in all 5 settings of care, and highlighting that the service users of those different settings do differ, particularly for mental health, which, whilst low in numbers, have high mean service use costs. And secondly, the value of linked datasets. They do provide extensive opportunities to improve our understanding of service use patterns and the wider determinants of health by looking at that wider breadth of variables and context in which the individuals are living. Thank you for listening to our presentation and for showing an interest in the research that we've conducted. If you have any questions, please do comment below the video, or alternatively email me at jenny.shand@uclpartners.com. Many thanks.